So in the next 20, 25 minutes, I believe I have, 30 minutes, I'm going to discuss a topic that is very seldom addressed, but I think has a lot of implications in the management of diabetes. And since the diabetes complication control trials 20 years ago, the hemoglobin A1C has become the way we assess glycemic control long term. And many of us use hemoglobin A1C to decide the treatment and the intensity of treatment. Following the DCCT, the UK PDS in type 2 diabetes also says that hemoglobin A1C should be the target. And every single organization in the world who says to use A1C for target to decide the treatment and intensity. The other thing that we do in the day-to-day practice, because we don't have hemoglobin A1C every day, is to use fasting blood glucose or pre-meal blood sugars. And we very seldom do postprandial glucose assessment. And that's maybe the reason that the treatment is focused for A1C and fasting, that about half of the patients with type 2 diabetes and more than half of the patients, 2/3 of patients with type 1 diabetes do not achieve goal. So it is important for us to understand that hemoglobin A1C combines glucose excursion pre-meals and after meals. And there is good data that postprandial may be as important or more important in determining hemoglobin A1C levels in patients with type 2 diabetes. And of course, we've seen this, that after meals, glucose goes up. And the elevation of postprandial glucose excursion depends on hemoglobin A1C. The higher the hemoglobin A1C, the higher the glucose excursions that is going to be. So what determines the postprandial glucose excursion? So there are 5 large or big groups of things. First is the amount of insulin secretion, the amount of insulin reserve that the patient has, in particularly the first phase insulin release. Second, glucagon. We know that glucagon is the most important glycogenolytic hormone. So both insulin and glucose regulate the hepatic glucose production. But maybe more important than insulin is glucagon. And normally when we eat, glucagon suppresses, and that decreases the hepatic glucose production. We will discuss this in the next few minutes. The third thing is the size of the meal, and more important, what we call glycemic index. We will discuss that. Finally, gastric emptying and preprandial glucose levels. Let me discuss these 5 topics in more details. So, as we know, there's insulin is secreted in 2 phases. The first phase is where the insulin is stored in the beta cells, and you have high peak, and it occurs within the next 5 to 10 minutes after a meal, and is followed by the second phase that is slowly released during the next 120 minutes after a meal. Patients with type 1 diabetes don't have first phase or second phase, they're insulinopenic. Patients with type 2 diabetes, it is very well demonstrated, they have blunted first phase release. And what is of interest is that some of the medications that we will discuss in a few minutes have shown to restore the first phase insulin release. So in a patient with type 2 diabetes and a glucose greater than 180, they lose the first phase, then you can explain or understand why the patient is going to have postprandial hyperglycemia. We mentioned about glucagon. So here you have to your left is what happened during an oral glucose tolerance test or after a test meal with glucose levels. In the light blue is normal. In yellow is patient with impaired glucose tolerance. And in red and black or red, whatever color that is patient with type 2 diabetes. So that makes sense, that's right, much higher levels. In the middle of insulin, but I want you to pay attention all the way to your right, and that is the concentration of glucagon. After we eat, everybody that is normal is going to suppress glucagon because you don't need more glucose. It's already hyperglycemia of the meal. Well, patients with type 2 diabetes have a failure to suppress glucagon. And they remain, and that is the main reason why there is an exaggerated hepatic glucose production in patients with type 2 diabetes. So if you don't suppress glucagon, that now we can understand very easily why we can develop postprandial hyperglycemia. And it's not only in type 2 diabetes, but also patients with type 1 diabetes, they fail to suppress glucagon concentrations. The third thing that I mentioned before is the glycemic index. That's right. We know that if we eat white rice versus jasmine rice, there's much more hyperglycemia with white rice. If you eat rice with lentils, there is significant less hyperglycemia after a meal. And they are both carbohydrates. It's just that they're different, what is called glycemic index, or the ability of some food, some nutrition to produce more elevation of glucose levels. So when we have a patient with poorly controlled diabetes, it is so important to send this patient to a nutritionist to discuss with them what are the food that they can consume that they are going to have low glycemic index. So if you have somebody with normal fasting, high hemoglobin A1C, always think about the dietitian, the nutritionist, because they may really help these patients in educating them to avoid bread, to avoid things like that, that may help to develop a better glucose control. The third is the postprandial excursion of glucose. As I mentioned to you, and you have different people who have different hemoglobin A1C in this curve, the highest the hemoglobin A1C, the highest the postprandial glucose excursion that you're going to have in your patient. And that has been demonstrated in multiple trials. This is the data, very classic for Monnier. And what you have in here is, this is a study on patients with type 2 diabetes, all of them managed with oral agents. And in patients with type 2 diabetes, what you have is, with oral agents, is that with hemoglobin A1C greater than 8.5, or greater than 8, the fasting stage is more important than the postprandial stage. So, and what you have in there is that those who have hemoglobin A1C less than 8, especially less than 7.5, the contribution of postprandial glucose is more important. So now let me put this in the very practical point. You start somebody on metformin and sulfonylureas, 80% of people in India in that combination. That's right, 70%. Well, the metformin and the sulfonylureas do not cover postprandial. They just increase insulin release, and there's not going to be much more control of diabetes. And if you look in this in red, it's the contribution of postprandial glucose. So when you have somebody, and you bring this patient very nicely from hemoglobin A1C of 9 or 10, they come to a hemoglobin A1C of 8, and there is a stop. And you cannot achieve goals because the sulfonylureas or the metformin does not cover postprandial. So if you really want to achieve glycemic control, you would need to add a third agent to control postprandial glucose excursion. And we know very well, and this doesn't project very well, but this is patients with the higher the hemoglobin A1C, the higher the glucose, okay? So why do we care about postprandial hyperglycemia? There are several studies that have implicated that postprandial hyperglycemia is equally or more important than fasting blood glucose, and perhaps even more important than hemoglobin A1C in complications. Postprandial hyperglycemia has been associated with increased rate of retinopathy, markers of atherosclerosis like increased carotid intimal thickness. There's also macrovascular disease, myocardial infarction, and more importantly, oxidative stress. There are a large number of observational studies that have implicated that postprandial hyperglycemia, and I understand it's very hard to read these tables, But all of these studies, more than 20 different studies, have shown that postprandial hyperglycemia is associated with decreased risk of cardiovascular events. So if we really want to, and why is that? It's because hyperglycemia and hypoglycemia are associated with inflammation, and also in oxidative stress. And oxidative stress is associated with endothelial dysfunction and has been implicated in the progression of accelerated atherosclerosis. So all of these studies have shown that there is this association. Likely, the explanation will be inflammation and oxidative stress. The problem that we have, and we're going to discuss this in a couple of minutes, there had been no intervention targeting postprandial hyperglycemia that have shown to reduce cardiovascular events. So that is the missing link that we have. We understand that postprandial hyperglycemia is important. The treatment is not very clear. Nevertheless, we have recommendations from different societies. I just put here the ADA and the American College of Endocrinology. And what they suggest is to keep the ADA hemoglobin A1C less than 7 for most people. I'm a member of the ADA Clinical Practice Recommendation Committee, and we decided last week or 2 weeks ago that next year we're going to say, keep hemoglobin A1C less than 7 for most people if there are not chronic complications, there are no hypoglycemia, just regular type 2 patients, 70% of your patients. For those who have complications, we're going to suggest a hemoglobin A1C less than 8. So if you have somebody with multiple complications, hypoglycemia, maybe you should target less than 8. And we're not going to suggest anymore a hemoglobin A1C less than 6.5 as the American College of Endocrinology. Now, A says keep the hemoglobin A1C less than 6.5 if you can achieve this without hypoglycemia. So the ADA is 7 is good enough. We don't have good documentation that below that you're going to achieve more reduction in complications. And you may increase the risk of cardiovascular events, especially in those patients who have long-standing diabetes. The second thing is the fasting plasma glucose, and both of them say 80 to 120, 80 to 130. To me, that depends who is in front of you. That's right. If I have an elderly person, complications, I just go from 80 to 150. Try to avoid hypoglycemia. And both says that postprandial should be controlled. The ADA is more flexible, less than 180. The ACE, less than 140. We do not have any data, and these are just recommendations of a group of people in a table and make this recommendation. We do not have any data that targeting this postprandial less than 140 is better than 180. So keeping less than 180 should be okay. So the problem that we have is that during the last few years or decades, we target fasting. We target hemoglobin A1C. And this is the editorial by Matt Riddle, the editor of Diabetes Care, that clearly makes the recommendation for us to target or to think about postprandial hyperglycemia if we want to achieve glucose control in our patients. So what armamentarium or tools do we have to control postprandial? In patients with type 1 diabetes, basal bolus, that's right. Use rapid-acting insulin before meals. It makes sense. The second is amylin analogs that I don't think you use it. I don't use it either. So in type 1 diabetes, there are also some studies using GLP-1. It doesn't work. There are also some studies with SGLT2 that decreases postprandial, but results in 10% ketosis, 5% DKA. So I don't think that, in like a recent editorial by David Nathan in Diabetes Care, in patients with type 1 diabetes, we should concentrate in a better delivery of insulin, using the combination of basal postprandial insulin in these patients. In patients with type 2 diabetes, we have several agents that have been shown to be effective in reducing postprandial glucose excursions. You have the basal bolus therapy, and you have the short-acting insulin secretagogue, you have acarbose, you have the GLP-1, DPP-4, and SGLT2. Let's review this data. So what about basal bolus therapy? Clearly important, that's right. It's the mainstay of postprandial. In patients with type 1 diabetes, it's the only way that you can go. And you're going to give, and the most important thing, if you're going to use Lispro, Aspart, or glulisine, it has to be given somewhere between 15 to 30 minutes before a meal, usually 20 minutes. I don't know what type 1 diabetics know what he's going to eat 30 minutes later. Impossible. Let's go, if I will have type 1 diabetes, I go to a restaurant, I'm going to order. I don't know how big is going to be the portion. I don't know how many carbohydrate units are going to be there. So it's very hard, extremely hard for a patient with type 1 diabetes to time it 20 minutes before. It is easy to do for research, that's right, and then you can see that it's flat. And that is the problem with type 1 diabetes, why they do not achieve goals. The other thing is that the recommendations of the ADA, ACE, and multiple societies is to do 50% basal, 50% prandial. And that is likely wrong. The recent data would suggest that the best way is to give 40% basal, 60% prandial dose of insulin, especially in type 2 diabetes. They are very insulin resistant. So timing of the insulin is extremely important. And of course, the ultra-rapid insulin that are coming in the market may help in that you only have to give the insulin 5 to 10 minutes before the meal. So you can look at it, the meal, in 5, 10 minutes, your plate is cold. That's right, your food is cold. So it's very impossible to do this in a very nice way. So what we do right now is to give basal insulin in type 2 diabetes. And basal insulin works well in reducing fasting and pre-meals, but it doesn't cover the postprandial glucose excursion. So what can we do? You can do basal bolus. So when do you move from basal to basal bolus? We discussed yesterday about this. If this is a paper that is hopefully is going to be accepted in Diabetes Care, in which we submitted and we took over 2,000 patients and we look at what dose you don't achieve any more benefit. So if you're giving basal insulin, 0.5, even 0.4 units per kilo, you don't gain too much. And before 0.5, your fasting glucose is not going to reduce. You achieve a plateau. So if I'm 80 kilos, 0.5, it will be 40 units. Above 40 units, and my hemoglobin A1C is elevated, I know that the problem is the postprandial state. So you better do something to cover postprandial. If not, the rate of hypoglycemia is markedly increased. So the ACE would suggest going, instead of basal to basal bolus, so from one injection to multiple injections, is that you ask your patient, what is your largest meal? And to do basal plus 1, plus 2, plus 3. Basal plus 1 means to give the dose of basal, and you give somewhere around 5 to 7 units of insulin before the largest meal. So you ask the patient, what's your largest meal? If you have somebody with a BMI greater than 30, that person eats 3 big meals. So you just put them on big things. But most of us has one large meal, and the others are small meals. If plus 1 doesn't work, you give the basal before the second largest meal, and then you add to the third largest meal, and that supposedly works very well. The problem is that basal bolus therapy, when you have somebody on metformin and you add basal, then you add prandial insulin, only 60% achieve goals. 40% of patients with metformin plus basal bolus do not achieve goals. Likely because of hypoglycemia, likely because of adherence or lack of compliance, it is very hard to achieve goals with basal bolus. So we have alternative. So first is the use of incretins. As you know, incretins are gastrointestinal hormones that do 2 main things. One is to increase insulin release, and the other is to suppress glucagon. And you can do that with DPP-4 or with GLP-1 receptor agonists. And both are very effective in increasing insulin and in suppressing glucagon, and that result in major effect is postprandial glucose excursion. In this study, you have a patient with type 2 diabetes who were given sitagliptin. And the same can be for any one of the DPP-4. And what you have there in black is pre-treatment, and in blue is post-treatment after 26 weeks of therapy. The main effect of the glucose reduction of the DPP-4 is in the postprandial hyperglycemia. If you give a DPP-4, you're going to get a reduction of hemoglobin A1c of about 0.6, 0.8%. But the reduction in fasting is just 10 to 20 milligrams, no more than that, 10 to 12, 20 to 14 different studies. The major effect is going to be in postprandial glucose excursion. The same thing is with GLP-1. Where it works, GLP-1, yeah, it works some in fasting state. It reduced hemoglobin A1c about 0.8, 1%. But the major effect in preventing this before and after, in this case using liraglutide or exenatide, it just doesn't make any difference. What you're going to do is to reduce postprandial glucose excursion. The other thing, in the literature, there have been several studies, and you have different GLP-1s. That's right. You have GLP-1 that are given twice a day, like exenatide, Byetta, like lixisenatide that is not really commercialized. You have liraglutide that is once a day, and you have several now that is once a week. The short-active GLP-1, like lixisenatide or exenatide twice daily, have a better glucose control postprandial compared to the long-acting. In clinical practice, that doesn't make any sense. To me, it doesn't make any sense. I just use any one of the GLP-1s because all of them have been shown. But if you're ever asked which is better to cover postprandial, are the short-acting GLP-1. The other thing that the GLP-1 does is to reduce appetite. There have been several studies. You invite people to eat in a buffet, and people time to how much you eat and what type of food you eat. 6 weeks later, with GLP-1 in therapy, you have the same experiment, and people have been shown to eat much less. And that is one of the main reasons why GLP-1 is associated with weight loss, is because it increased satiety. A major problem of obese and patients with diabetes is polyuria, polydipsia, and polyphagia. And this is where GLP-1 works, and there are several experiments have been shown that GLP-1 improves satiety, and more importantly, decrease appetite in a lot of patients. And the increased appetite is not related to nausea. Finally, GLP-1 also improves postprandial glucose excursion because it delays gastric emptying. And this is a dose-response effect. And we empty our stomach 90% in about 2 hours. And a patient with type 2 diabetes treated with GLP-1, this is extended all the way up to 4 hours. So we have basal insulin, we have GLP-1s. And I think this slide is very powerful. This is what we do in practice. That's right. You have people taking oral agents, you add basal insulin, you got GLP-1 by itself. But here to the left is how many patients achieve goal, a hemoglobin A1c less than 7, taking GLP-1. And to the right, how many people with basal alone, glargine, deramir, degludec, achieve goal by itself, about 30-40%. But itself, and this is extremely important, if you have somebody on oral agents, you put basal insulin, only 40% achieve goals. If you do it with GLP-1, about the same. So what you need to do is to combine these agents. The combination of insulin and GLP-1 with, like we discussed yesterday, could be basal and DPP-4, are very effective in the way that GLP-1 works in many other mechanisms that we discussed. delayed gastric emptying, suppression of glucagon that is not done by glargine alone or deramir alone or degludec alone. So keep that in mind. If you do not achieve goal and you're giving basal insulin more than 0.5 units per kilo, you should think on adding something else. And now we have in the same insulin, in the same formulation, that's right, combined. And you'll see here, this is just an example of iGlarelixy, that you start with it's the only way that you're going to achieve a hemoglobin A1C around 7. Much more effective than insulin alone, much more effective than the GLP-1 alone. And when I'm to bring your attention to the right side. And this is the reduction of postprandial glucose excursion. You achieve a hemoglobin A1C reduction of 1.5, 2% with a postprandial glucose excursion reduction about 60 milligrams. And this is a very important slide. So the way that we have been taught, and I'm very much involved in this guideline thing, is we tell people to start diet and exercise, the most important thing, especially with postprandial. And they say start metformin, combine oral agents, and they fail. That's right. Sooner or later they're going to fail, and you have to start insulin. And basal insulin is great, but only 40% achieve goals. And the three most important agents in practice we use are GLP-1, DPP-4, and also SGLT2. Are SGLT2 good in reduction of postprandial glucose excursion? And the answer is yes. Here you have a study in which they combine canagliflozin with DPP-4, in this case was sitagliptin. And you have there, if you use sitagliptin in red, you get a reduction of hemoglobin A1C about 0.8, 1%, and look what happened when you use cana. And this is both fasting, and to the right is the reduction in postprandial glucose excursion. So the combination of a DPP-4 and a SGLT2 is very powerful. And I use combination of GLP-1 and SGLT2 in patients who has poor controlled diabetes, especially if they are obese and overweight. This is something that we are contemplating and with the ACE, we have done this for the last 3 years, and with ADA, it's kind of evolving to this. The paradigm needs to change. The paradigm of type 2 diabetes has been you fail oral agents, you start basal, and you go to the right and the left. Go to basal bolus insulin. That is associated with increased body weight, about 2 to 4 kilograms, increased rate of hypoglycemia, patient dissatisfactions in the way that you have to take 4 injections a day, and more importantly, somewhere around 40% of patients that goes to the right and the left do not achieve goals. What we are proposing right now is that going to the right and the right. If you fail to basal insulin, the next step is combination of injectables. The other possibility is to use DPP-4. It's not as potent as GLP-1, but it's acceptable and it's oral with very little side effects. And as I showed you a couple of minutes ago, the combination of SGLT2 is very powerful in control postprandial glucose excursions. The route to the right, I believe, is preferable right now to the right and the left. And I believe that in the future, in patients with type 2 diabetes, the basal bolus will be more history, because we're going to go to the right and the right, because it's more effective in controlling postprandial glucose excursions. So the message to take home is that we should use basal. Yeah, no problems. But understand that about half of the patients do not achieve goals. And there's your choice to go to the left or to the right. I favor the route to the right. Now, can 70-30 do it? Some study would suggest that 70-30 is not better than basal insulin alone. So I think that the route to the right, using GLP-1, DPP-4, or SGLT2 should be much more preferable. So, and we leave a few minutes that you can back, or you can have questions or comments. Any questions or comments?
Thank you, sir. Thank you for that excellent session. Any questions, comments from the audience?
Okay. PJ.
Talking about the postprandial blood sugar, until 2005, there was no understanding as to what should be the normal cutoff value for the postprandial blood sugar. It was the IDEC for the first time defined 145 as a postprandial blood sugar in any patient. American Diabetic Association has given the figure of 180, and it says that the peak post-lunch blood sugar, postprandial blood sugar, it's called peaked. What is the meaning of the word peaked post-lunch blood sugar?
It depends how much insulin you have and what you eat, that's right. So all of these numbers are very arbitrary, extremely arbitrary. It's the same thing, for example, the American College of Physicians now calls for hemoglobin A1C 7 to 8 for most people. I mean, there are arbitrary criteria and interpretation of the data. In postprandial hyperglycemia, we understand the strong association with complications. But there's no studies that trying to target postprandial has reduced complications in this patient. So I think that what we have, and all of this study has been done with the primary outcome is hemoglobin A1C since the DCCT and UK PDS. There's one study that's called flat sugar, and that study was done by Earl Hirsch at the University of Washington in Seattle. And he used exenatide in combination with basal insulin, and that reduced postprandial stage. No significant difference in complications, although the trial was not long enough to achieve goals. So if you use 145, 140, 180, I think it's the same. I believe the ADA is more conservative, it's more realistic. I mean, and we're not going to change the guidelines. The ACE, I believe ACE is going to be more flexible in the way that there is no good data that 140 is better than 180, 145. It doesn't make any difference at all. Yeah.
Professor,
So, a couple of quick questions. One is use of oral anti-diabetics to combat postprandial hyperglycemia, especially drugs like alpha-glucosidase inhibitors or repaglinide, nataglinide, that group. Where would you place that? And there's one more, you can ask that first.
Yeah, and of course they do work. And there is a study published in the Annals of Internal Medicine that alpha-glucosidase inhibitor is as good as metformin, especially in elderly person in improving glucose control, hemoglobin A1C. Metformin is a fasting, AGIs are postprandial stage. In the United States, we use very little AGI, and I know you guys use it much, much more than we do, but it's an option that we have. Repaglinide is a short-acting. It may work the same as nataglinide. It's associated with increased risk of hypoglycemia or similar incidence of hypoglycemia compared to the other sulfonylureas. I think that we have better treatment with the DPP-4 and the GLP-1. AGI is a great consideration for the elderly person if they can tolerate. I do agree with that.
So the other question pertains to what is the peak actually, because we just look at 2 hours value and say that's the sort of cutoff that we use, but actually the peaks are all over the place in different people. So, if you know that in pregnancy we use 1 hour, in so many situations maybe hitting 200 at 1 hour. So we don't have real data. Do you have any feel about that whether overall postprandial needs to be blunted, ideally, if we are looking at
it? It all depends on multiple factors that I showed before. So, and the guidelines are guidelines, that's right, and it makes sense. 180 sounds okay. You can push it to 140. I think that is not rational for a patient with diabetes. I think that the best description of postprandial hyperglycemia is a glucose greater than 180.
Professor Umpierrez, here, at the stage only.
Oh,
yeah.
The stage, yeah. This is regarding the extension of Dr. Mittal's question. Postprandial 2 hours, as he has suggested, and postprandial 1 hour. There are some studies which says that postprandial 1 hour is still more important than postprandial 2 hours, as far as the micro and macrovascular complications long term is considered.
Yeah.
So which you think, postprandial 1 hour or 2 hours?
So there are several studies have asked that question, that's right, which is more sensitive. And where we have the 2 hours for diagnosis of diabetes and long-term complications. There are some people who picks at 1 hour, some others at 2 hours. I think the 2 hours is better accepted in the literature. We just published a paper about 3 or 4 years ago with 3,000 patients using 1 hour. And it worked. But I think it's no different from the 2 hours relate to complications or overall glycemic control. So you can do 1 hour, 2 hours. I think 2 hours is better to the patient. Thank you very much.
Thank you very much.